The issue of diffuse lung disease is one of the complicated topics in radiology, and there is a recent classification of the approach of how to handle this hard topic. You know, in order to interpret the chest X-ray, you should have first an optimal quality radiograph, and you should fulfill the patient data. And if the previous films are available, this will be of great help. Then, starting the interpretation, you should discriminate between what's known as focal lung disease and diffuse lung pathology. Focal lung disease means that you have a single or multiple lesions, but the rest of the whole lung is clear. Diffuse lung disease means that both lung fields are involved by some of the pathology or opacities, and will this is the CT scan of a focal lung disease and a diffuse lung disease. And one of the basics for imaging of diffuse lung disease is to have what's known as high resolution CT. In high resolution CT, it's just a technique used by the technician to produce imaging of high resolution, and you can compare the conventional CT scan and the high resolution CT scan. Then you can see more details compared to the conventional one. You can see the dilated bronchi, and you cannot see here. You can see some of the peripheral opacities underneath the pleura, and you cannot appreciate this very well. So, in order to evaluate a diffuse lung disease, we should have what's known as the high resolution CT. It should be requested by the clinician. This is the difference between conventional CT and the high resolution CT. The bronchiectatic changes are not seen here. The fissure between the lobes is not also seen here, and you got more details about the opacities in the lung. Sometimes, especially in old age, whenever you scan a patient in the supine position and you got these opacities, and these are just secretions that have settled down while the patient is in the supine position. And in order not to misinterpret these as opacities or interstitial lung disease, sometimes you may want to put the patient in the prone position and you scan once more. Then you can see that the areas that were opaque are now clear. And this is a fact that you should consider in the interpretation of these images, that in old age in particular, many of the patients will have such opacities, and this is nothing but some of the dependent secretions. And also, we may have this technique to augment the lung pathology. This is an inspiratory CT and expiratory CT. And in patients with asthma, for example, there is sometimes you can see areas of air trapping. And these areas are not seen unless you have this expiratory CT. In the inspiratory CT, you can see that the lungs are almost clear. But here, you can see areas of hypertranslucency representing trapped air. This is the normal lung during expiration, and these are areas of air trapping. Then, how to look at the radiographs and the CTs of a patient with diffuse lung disease. We should first identify the pattern of this diffuse pathology. Look at the normal lung, and we have 4 patterns. This is the first one, which is known as reticular pattern, where you can see too many linear opacities scattered throughout the lung field. By the alveolar pattern, we mean that you got multiple areas of consolidations, and these areas of consolidations may contain air bronchogram. Then the nodular pattern means that there are miliary shadows scattered throughout the lung, and the cystic pattern means that you got multiple air-filled cystic spaces scattered throughout the lung. And this is not cystic lung disease. This is cystic pattern of diffuse lung disease. Cystic lung disease is a congenital pathology, but this is an acquired disease that has many underlying factors. Then we have also a pattern which is not included in the four patterns mentioned before, that is the ground glass pattern. The ground glass pattern means that you got some opacities in the lung that make the appearance of the lung is not that clear like this normal lung. The ground glass pattern can be seen in every case of diffuse lung disease. But whenever it is seen alone, it means something. Whenever it is seen with other opacities, we interpret the case according to the other opacities present in the lung, as I will explain to you. Then, if you look here, and there are miliary nodules that are scattered in the lung, and this is miliary disease or nodular disease. And here you can see multiple cystic lesions that are filled with air diffusely scattered in both lung fields. And then how to interpret the diffuse lung disease. First of all, we need some clinical data, and these are of extreme importance for the radiologist in order to be able to select the possible diagnosis or the differential diagnosis. Number one is the presence of fever, and this is very important. Presence of hemoptysis and the history of smoking, which is extremely important in some diseases, and also exposure to certain substances like allergens, which can cause the allergic lung disease. I will show examples of this. Then the distribution of the lesion. Where is the lesion? Is it interstitial or reticular pattern? Is it alveolar pattern or biliary or cystic? Then the pattern in relation to distribution, if the lesion peripherally located or centrally located, is it in the apex or in the base? And this also will help in the differential diagnosis. And additional imaging findings, the presence of lymphadenopathy is important, and also the presence of pleural effusion is important. Then you should look for the chronicity of the findings. Are the presentation acute or long-standing? Then if you look here, and this is the normal chest radiograph, and the first 3 centimeters of the lung, the peripheral 3 centimeters of the lung, is known as the peripheral areas. And this 3 centimeters should also on either side of the fissure. This is considered also a peripheral distribution of the pathology. And the central distribution means that you have opacities in relation to the cardiac shadow and the hilum. Then you know all about the pulmonary lobule, which is a hexagonal in shape, and it contains one of the pulmonary artery branches and pulmonary veins and some of the respiratory bronchioles. And this can be let's say seen in the CT, but in conjunction with other lobules, as I will demonstrate to you. And secondary pulmonary nodule is a polygonal shape composed of respiratory acini connected to the terminal bronchioles. The number of the acini, and this is not important for you, may range from this according to the size of the lobule itself. Then this distribution is one of the important distributions in diffuse lung disease. And whenever you see it, and you can swear that this disease is so and so. I will demonstrate to you. And if you see lymphatic distribution, and we mean by lymphatic distribution, thickening of the borders of the lobule, as well as its attachment or its relation to the pleural surface. Then if you look here, and this is classic distribution of lymphatic pathology. If you see this classic distribution, and you see one of the easiest way is to go to the fissure in between the lobes, and you can see these nodules on both sides of the fissure. This will help you to feel that this is lymphatic distribution. If you see lymphatic distribution, there are only 4 pathologies that can produce this distribution. The most important one of them is sarcoid. Then you got pulmonary edema, lymphangitis, carcinomatosa, and pulmonary lymphoma. If you remove pulmonary lymphoma, which is considered a little bit rare, then you consider the 3 pathologies here: the interstitial pulmonary edema, sarcoid, and the lymphangitis carcinomatosa. Yes, sir. Okay. Lymphatic distribution means that, and you know that the respiratory lobule, there is an interstitial space in between the lobules where lymphatics can go through. And if there is a disease which affects particularly the lymphatics, you will got these opacities. And if you see these opacities, you know that this disease should be one of 3. Either it is pulmonary edema, and you look for the cardiac condition. Either it is sarcoid, you look for lymph nodes in the mediastinum, or lymphangitis carcinomatosa, you look for a primary malignancy in the patient. Okay?
So this CT scan,
Yeah.
the body is looking at the thickening of the septum and the
Yes. Yes.
So the fissure is the one which is
This one.
Yes.
Yeah.
So when you say both sides, it's anteriorly and posteriorly in the lymph nodules.
On both sides. Yeah. Okay. Then, if you are looking to the chest X-ray or a CT scan, and you see the reticular pattern, how can you diagnose the reticular pattern? You look for the chest X-ray, and you see that there are too many linear opacities in the lung. But any one of you can say, no, I am looking for nodules, for example, yes? And anyone also, I feel that these are batches. Can you feel this? Yes, okay, and this is absolutely right. What is how to verify the underlying pathology? We should have the high resolution CT. Then, whenever there is a conflict in the plain X-ray, then we should go to the high resolution CT to be sure. What about the nature of the pattern of diffuse lung disease? And if you now are dealing with in reticular pattern, what are the possibilities of the diseases that can induce reticular opacities in the lung? Number 1 is interstitial pneumonia. Number 2, interstitial pulmonary edema. Number 3, idiopathic pulmonary fibrosis. Then collagen vascular diseases like rheumatoid, systemic lupus, and so on. Drug-induced diseases, radiation-induced lung disease. How can you separate these pathologies from each other? Then you know both types of pneumonia, the usual one and the non-specific one, are very easy to diagnose. We start by both usual interstitial pneumonia and the non-specific interstitial pneumonia. There are the most 2 common forms of interstitial lung disease. And you got extensive pulmonary opacities, linear opacities in the lung. And the prognosis will depend on which type you are dealing with. Are you dealing with non-specific or the usual interstitial pneumonia? Usual interstitial pneumonia, if it is of unknown cause, it is called idiopathic pulmonary fibrosis. Okay, you understand this point? This is very important. The usual interstitial pneumonia, if there is no detectable underlying cause clinically, then you call this idiopathic pulmonary fibrosis. There are too many causes for this disease, and this is a progressive disease of poor prognosis, and it affects usually females above the age of 50 years, and it usually presents for more than 6 months of complaining. Then it does not respond to corticosteroids and is usually of poor prognosis. How can you diagnose usual interstitial pneumonia? We have two major findings here. Actually, you should feel first that there are too many linear opacities in the lung. But the two main important findings for the diagnosis of usual interstitial pneumonia are: number one, traction bronchiectasis, because fibrous tissue pulled on the wall of the bronchi, resulting in their dilatation. And number two, this classic appearance, which is known as honeycombing. And honeycombing means that you got cluster of small cystic lesions peripherally located adjacent to the pleura. This is the honeycombing, and these are areas of honeycomb. Honeycombing is one of the classic points essential for diagnosis of usual interstitial pneumonia. And what's honeycombing? This is the cluster of cystic air spaces in the range of up to 1 centimeter in diameter. They are subpleural in location, and this is the gross appearance of honeycomb. Uh, Whenever you see diffuse lung disease and you got too many opacities in the lung, and you should start to look first for: do you see traction bronchiectatic changes? Do you see honeycombing? Then the diagnosis is usual interstitial pneumonia. And here, can you see traction bronchiectasis? Can you see too many areas of honeycombing? Then this is usual interstitial pneumonia. If this usual interstitial pneumonia has no underlying clinical disease, then you call it idiopathic pulmonary fibrosis. You understand? Okay. Then we came to the non-specific interstitial pneumonia. It is exactly similar, but occurs more common in men, and the age is relatively younger, and this disease responds to corticosteroids. All the findings of usual interstitial pneumonia are seen here except honeycombing. Except honeycombing. Then you got opacities. We call this ground glass opacities, and you got traction bronchiectasis, but you do not get honeycombing. And this is the essential difference between non-specific interstitial pneumonia and the usual interstitial pneumonia. In here, you can see traction bronchiectasis, but you cannot identify any honeycomb. It is possible to see minimal areas of honeycombing in patients with non-specific interstitial pneumonia, but honeycombing is evident in usual interstitial pneumonia. You see here multiple areas of traction bronchiectasis, minimal areas of honeycombing, and this is non-specific interstitial pneumonia. One of the findings, according to the literature, is that if you look carefully, If you look carefully, you can see that the opacities do not affect the most peripheral part of the lung. You can see these arrows points to that this subpleural area of the lung is relatively clear. And you see traction bronchiectasis, you do not see honeycombing, and you see relative clearance of the peripheral part of the lung. This is diagnostic of a non-specific interstitial pneumonia.
For purpose of bronchiectasis,
Yeah.
is there like a cutoff size? You say this
No,
contraction
no.
just daily dilatation.
There is actually a size to say that this is normal bronchi or abnormally dilated bronchi. You just look at a bronchus and the adjacent vessel in cross section. It is normal to see that the vessel is of the same size of the bronchus. But in the recent classification, it's allowed to that the bronchus is normal, even it is 1.5 compared to the adjacent vessel. Okay, but if it is double the size of the vessel, and then you got traction bronchitis. It's better to see the dilated bronchi along the longitudinally oriented sections, not for the cross sections. Okay. Yeah. This is one of the suggestions by the clinicians. They said that the ground glass opacities are the precursor of interstitial lung fibrosis, and you can give corticosteroids to prevent the progression of the disease. But actually, the ground glass will be seen in all the patterns of diffuse lung disease. And I will explain after a few minutes. If you see pure ground glass without any other opacity, what to do? Then you remember that we have in the interstitial disease, you remember the list. Number one, usual interstitial pneumonia and non-specific interstitial pneumonia, interstitial pulmonary edema, and idiopathic pulmonary fibrosis. Then you got collagen-related interstitial lung disease, radiation-induced and drug-induced. When we came to the pulmonary edema, we have two types: interstitial edema and alveolar edema. Interstitial edema may be due to cardiac problems and may be due to non-cardiac problems. And this is just to remember the causes of non-cardiac problems causing interstitial pulmonary edema. You remember by these letters: near drowning, oxygen therapy, transfusion, neurogenic pulmonary edema, allergic alveolitis, renal failure, some drugs, inhaled toxins, high altitude, and pulmonary contusions. Then, if you look to the chest X-ray with interstitial pulmonary edema due to cardiac problem, then you got enlargement of the cardiac shadow and too many interstitial opacities. Then how can you know that these are interstitial opacities? You go to the high resolution CT. And how can you know that this is cardiogenic pulmonary edema? You look to the cardiac shadow. If the heart is enlarged and you got like this pacemaker and you got left ventricular dilatation, look carefully at the costophrenic angle for these linear opacities at the costophrenic angle, which represents the B Kerl's line. You know, B Kerl's line. Then I will magnify this so that you can see what I mean by the B Kerl's line, and you got some more longer opacities near the hilum, and these are the A Kerl's line. These are this patient with a previous chest X-ray, and this is after 10 days, and you got left ventricular failure with extensive interstitial opacities in in the lung, and you got too many B Curlis line and also the A Curlis line. Then these are the A Curlis line near the hilum, and this is the B and C Curlis line near the costophrenic angle. Then collagen related is many diseases like scleroderma, like rheumatoid arthritis, can induce interstitial pulmonary disease. And this disease at that time is known as collagen related. Then, if you know that this patient had scleroderma and you call this scleroderma interstitial lung disease, if you know that he has rheumatoid, then this is rheumatoid induced interstitial lung disease. At that time, you can see a picture which is exactly similar to usual interstitial pneumonia. You know, but why we call this scleroderma related? Because we know the underlying cause. You remember, if you do not know the underlying cause, you call it yes, idiopathic pulmonary fibrosis. Then this patient with scleroderma. One of the signs of scleroderma in the chest X-ray is you got dilatation of the esophagus, and it also may be seen in the CT scan. It's not evident in this case, but it's helpful in the exams, for example. Then you got these opacities, and you got air trapping, and you got ground glass, and you got honeycombing, and you know that the patient has scleroderma, is complaining of dysphagia, and this is a scleroderma related lung. This is also another example of scleroderma related interstitial lung disease, and you see the extensive opacities through both lung feet. And this is another example of rheumatoid interstitial lung disease in a patient with long history of rheumatoid arthritis, which complaining of chronic shortening of breath. Then you see ground glass, interstitial opacities, and you may got some areas of honeycomb. Yeah, I will explain this in details. Okay. Then you know the stages of sarcoidosis I will explain also, and the end stage, which is the fourth stage, where you got extensive pulmonary fibrosis. But you know from the start that this patient had sarcoid. Then you call this sarcoid induced interstitial pulmonary fibrosis or in the interstitial lung disease. Then there are certain medications that can induce interstitial lung disease. Some of them are related to the cancer therapy, and others are anti-inflammatory or also. And if you know that the patient is receiving one of these drugs and you got opacities throughout the lung, and you know that this is a drug-induced interstitial lung disease. Then you came to the lymphangitis carcinomatose. I said if you have interstitial opacities in the lung, in the lymphatic distribution, I showed you the lymphatic distribution, then the patient is known to have a primary malignancy, then you consider this lymphangitis carcinomatose. And that's to say that malignancy has spreaded by the lymphatic route. And here you got this patient with esophageal malignancy, and you got many opacities in the lung, and that diagnosis is lymphangitis carcinomatose. This patient had a breast cancer. You see the lesion in the breast. These images usually are used in the exam because you are frequently miss the lesion, the primary lesion. Then you see too many interstitial opacities in the lung, and this is the primary malignancy. Then you know that this is lymphangitis carcinomatose. This patient with chronic myeloid leukemia, you got interstitial opacities in the chest X-ray, and the diagnosis is lymphangitis carcinomatose. This patient with gastric cancer, extensive pulmonary opacities on both lung fields by CT. You can see these opacities, and first they are treated as pneumonic areas or pneumonic consolidations with no improvement, and instead there is progression of the disease, and this was lymphangitis carcinomatosis. This patient is known to have breast cancer, non-Hodgkin lymphoma, and you got interstitial opacities. The diagnosis is lymphangitis carcinomatosis. You remember the lymphatic spread and the CT scan? If you see this, and then you know you are dealing with one of three: sarcoid, lymphangitis carcinomatosa, and interstitial pulmonary edema. If you know that this patient is one of the patient had a primary malignancy, then you consider the diagnosis of lymphangitis carcinomatosa. Then we finish the first pattern, which is the interstitial or the reticular pattern. We said that we have about 6 in the differential diagnosis. What are these 6? What are? Interstitial pneumonia, hmm? Drug-induced, collagen-related, radiation-induced, interstitial pneumonia we have said, interstitial pulmonary edema, and the last issue is idiopathic pulmonary fibrosis. Then we came to the ground glass pattern. Remember, the ground glass means that you got some veiling or opacity in the lung that is not similar to consolidation. It's just veiling of the lung. And this is a descriptive term. And anything involving the alveoli or the interstitium can induce ground glass opacity. So, if you see ground glass opacities in the lung, this is not a specific disease. It is a lung pathology with a hidden underlying lung disease. And if you wait for some time, then you can see the original pathology, which is most commonly interstitial lung disease. But if you look here, then you got many patches in the lung representing areas of ground glass pattern. Then, what do you think these areas represent? You do not know. You should correlate with the clinical picture of the patient in order you can reach a specific diagnosis. Previously, they thought that whenever a patient had an a ground glass pattern, then you look to the history. If the patient is known to have HIV, then you are dealing with pneumocystis craniae pneumonia, which is currently known as pneumocystis jirovecii pneumonia. Then, if the patient is known to have lung transplantation, and you see in the transplanted lung areas of ground glass opacities, you know that this is cytomegalovirus infection or the lung is rejected. Okay? Then, the current differential diagnosis depends on whether the ground glass pattern is acute or chronic. If it is acute, you consider these possibilities. If it is chronic, you consider other possibilities. Acute ground glass pattern means that you are dealing with pulmonary edema, which is cardiogenic, or acute respiratory distress syndrome, and a type of pneumonia, which is viral pneumonia or pneumocystis craniae pneumonia if the patient is known to be HIV positive. Pulmonary hemorrhage, and this is very important, which is known as acute eosinophilic pneumonia. Then, if you see a ground glass pattern alone, and that presentation of the patient is acute, then you know the possibilities are pulmonary edema, either cardiogenic or acute respiratory distress syndrome, viral pneumonia or AIDS-related pneumonia, pulmonary hemorrhage, or acute eosinophilic pneumonia. And we have said that the pulmonary edema is either interstitial or alveolar. Interstitial pneumonia, we explained, you've got too many opacities in the lung in the interstitial distribution, and it can be cardiogenic and can be non-cardiogenic edema. And what is acute respiratory distress syndrome? This is a lung injury leading to permeability edema with too many opacities in the lung. This disease affects any age group. It can be seen in the pediatric patients. And this is in contrast to the cardiogenic edema, which is usually seen in adults. Then patients are usually severely distressed and they are in the ICU, they are intubated usually, and they give positive oxygen treatment. Then these are the predisposing factors of acute respiratory distress, which are similar to the non-cardiogenic causes of pulmonary edema, and they are almost the same. Then, if you look to the X-ray or the CT scan and you got extensive opacities, but these opacities are not associated with enlargement of the cardiac shadow. There are no pleural effusions and no careless lines to differentiate it from interstitial edema. But you see the opacities with some air bronchogram inside denoting pulmonary consolidation. The onset of the disease is usually delayed for about 12 hours after the insult, one of the causes previously mentioned. Then between 12 and 24 hours, you get patchy alveolar opacities. Up to 48 hours, you get massive pulmonary consolidation. Within 5 to 7 days, the opacities start to clear, and this is because of ventilation rather than actual healing of the disease. After 7 days, the disease may progress to fibrosis, and you got the full-blown picture of interstitial pulmonary fibrosis. Then CPAP, which is continuous positive airway pressure, has too many complications, including the pneumothorax, pneumomediastinum, and pulmonary interstitial edema, but this is the way how to treat such cases. The pneumocystis pneumonia, recently known as pneumocystis jirovecii, and this is the HIV-related pneumonia. If you know that the patient is HIV positive, then any changes in the lung, if they are in the form of reticular opacities or consolidative opacities, you consider the possibility of pneumocystis jirovecii. Then these are the findings of pneumocystis jirovecii pneumonia. You got ground glass opacities, which are evident in this particular type. You got septal thickening. You got nematoceles. By nematoceles, we mean that you have areas of air trap like cysts filled with air. And nematoceles may rupture, causing pneumothorax. Pleural effusion is rare, and lymphadenopathy is also rare. Then, if you know that this patient is HIV positive, any changes in the lung considered as pneumocystis jirovecii pneumonia. These are what I mean by nematoceles. You got multiple areas filled with air, cyst-like structures, together with extensive areas of ground glass opacities. And HIV positive patients may have this pattern of pneumonia, and also anyone who is immune compromised can have this type of pneumonia. Like this patient, which is a woman receiving steroid therapy for collagen vascular disease, and she is 65 years old. Because of age and this steroid therapy, she is relatively immune compromised, and she got this type of pneumonia, but it's very common in HIV positive cases. Then we came to this type of pneumonia, which is very important to know. You got this patient is the presentation is acute, and you got many opacities in the lung, similar to the previously mentioned one. But there are some specific points that can lead you to the correct diagnosis. The cause of this eosinophilic pneumonia is not known, but if you are able to see peripheral eosinophilia in the blood picture, or to see an eosinophilia in the bronchoalveolar lavage, this is diagnostic. But one of the big issues in the clinical practice that you see in the chest X-ray what looks like pneumonia. It is pneumonia, and the patient is feverish, and the patient is exactly the patient of pneumonia. You give him antibiotics, no response. And this is one of the basic criteria that should change your mind that this is not the usual type of pneumonia you know. Then you have two ways to reach the diagnosis. Either you see eosinophilia in the peripheral blood count, or you see eosinophilia in a bronchoalveolar lavage. This is diagnostic. Then you give corticosteroids, and there is marvelous response to corticosteroids. Then the appearance of acute eosinophilic pneumonia in ground glass areas distributed everywhere, interlobar septal thickening, pleural effusion is common in these particular cases, and the consolidation is seen in about 50% of the patient. And also you may see some nodules, which is not essential for the diagnosis. And this male patient, 18 years old, asthmatic and smoker, presented by fever, productive cough, shortness of breath for 2 weeks, unresponsive to antibiotics. This is very important, or one of the clues to reach the diagnosis. Then you see here, and you got the patient follow up after 10 days of corticosteroid therapy, you get some improvement in his condition. Then the presence of multiple areas of consolidation or ground glass effusion, ground glass opacities, and these opacities do not respond to antibiotic therapy, then you may consider the diagnosis of acute eosinophilic pneumonia. Then this is an example where you can see multiple patchy areas of consolidation, and you may say that this is areas of pneumonia. Follow up after 10 days, you got total clearance of the lungs. And this is an important note, the fact that marked improvement of the patient clinical and radiographic findings after corticosteroid therapy make acute eosinophilic pneumonia the most likely diagnosis. Thank you very much.